Well, guys, listen, it's 6:35. Let's get the show on the road. I'd love to introduce Dr. Sasso to you guys. His introduction will be a little different, which is like I got to start listening to Dr. Sasso like 13, 14 years ago as a resident, as my memory of it. And I was very impressed back in the day, just how poised he always was. And then, like over the years, as I've gotten to know him, I've come to really trust Dr. Sasso. And you guys will hear me talk oftentimes about when you read articles, you always have to look at the author list. And it's important because as over time you'll get to know these authors, and some you'll end up believing and some you don't. But Dr. Sasso is one that I whenever I see a paper, I just know it's been thorough and it's honest. And so I'm really excited today on still a reasonably controversial topic to hear about TDRs. And I guarantee what comes out of his mouth is going to be gospel. So listen close. He's a wonderful educator and a great friend. So thank you for being here this morning.
Thank you, Greg. That was like the best ever introduction I've ever had. So thank you. I'm going to try. Where is the share my screen? Usually it's on the bottom here, but
it's actually on the top. So right next to the leave button, it says share with an arrow.
Oh, thank you so much. You're right. Okay. All right. Very good.
And then select the window that you want to share. So that would be your presentation.
So can you see it? Am I on now? Is it?
Yes.
Okay, great. Okay, so again, Greg, thank you so much. It's a huge honor for me to be here. I'm super excited about this, and I love doing it in this kind of format. And hopefully, we'll have some time, 10 minutes or so, to have some discussion. But what we're going to talk about is cervical disc replacement in 20 minutes or less, and it's going to be my 20 years of experience in 20 minutes or less. 20 years ago, last month, I implanted the first cervical disc replacement in the United States, and we are now actively following, getting our patients back for the 20-year follow-ups, and it's really interesting, and hopefully we'll have some good data in the next few months to present. But what this talk is going to be about is not any specific cervical disc replacement, but generic. It's going to be about my experience with using a whole bunch of different cervical disc replacements over the last couple of decades, and some of the things that I've learned, some of the things I've learned the hard way. And then at the end, we'll talk about some technique variations, things that I do differently for my cervical disc replacements versus ACDF. So a couple generic things that I've learned over the last couple decades. Number one, in big, large, big-chested, short-necked men, it's really hard to do a TDR at C6-7. And this is probably the most common reason that I abandon a artificial disc replacement and change it out for an ACDF. In my opinion, you absolutely have to see the back of the disc space to safely place an artificial disc. And many times, as you see in this guy, you can't even really see C5-6. There's no way we're going to see C6-7 here. And when we're doing an ACDF, you really don't need to see the back of the disc. All you need to do is be able to count accurately, so you can count, get your marker up here and then count down. And that's really all you need for an ACDF. But for an artificial disc, you absolutely, in my opinion, have to see the back of the disc space to safely place this. And sometimes this can be very, very hard. Also, don't do artificial discs in a patient with any type of deformity, whether you're going to plan to do it at the apex or even outside the deformity. You're going to be very, very sad, and you're going to be watching this artificial disc go over the years, and you're not going to be happy with it. So I'm going to tell you, in any type of deformity, please avoid artificial disc replacements. The other area that is tough is in patients that lay down a lot of bone. I call them bone formers. And these patients who just are genetically predisposed to lay down bone, there is a higher incidence of developing heterotopic ossification, as you see in this case right here. And so in these patients, really important to think about not doing it in an artificial disc. And we're talking specifically in just a moment about the posterior longitudinal ligament and how important that is in regards to laying down bone. And then also in those patients that have had multi-level fusions, I think that an artificial disc next to a one-level fusion is a very reasonable indication. But after a multi-level fusion, I've just seen too many complications, too many failures, and I think there's too much stress and strain, especially depending upon what artificial disc you use, to consider using this, at least at this point in time, next to a multi-level fusion. So what we're going to talk about now is sort of what I call tips and pearls, and basically what I do differently in an artificial disc compared to an ACDF. And specifically, we're going to talk about positioning. We're going to talk about how I define the midline, and a spoiler alert here, it's not with X-ray. I don't get AP X-rays. How important it is to place the pins, the distractor pins, parallel to the disc space. What I think about the PLL and what I do differently in regards to PLL, and the use of non-steroidals. And then finally, we're going to talk about end plate preparation for a moment, because I think that's probably the most common reason to get into trouble. So first off, what I do differently in regards to positioning, when I do an ACDF, I place the towel roll underneath the shoulders. But in an artificial disc, I actually place it underneath the cervical spine. We want to make sure that the patient is in a neutral position and not hyperlordotic. You know, when we place the roll underneath the shoulders, we get the chin out of the way, the head falls away, and we have a very nice big corridor to access the front of the cervical spine. But in artificial discs, actually place the towel underneath the neck rather than the shoulders. And what we want to do is we want to have the back of the head and the back of the shoulders on the same plane. That's the goal of this. And we don't want to hyperextend the cervical spine. The reason is that there's a tendency to take too much of the end plate posteriorly when we hyperextend the cervical spine. And that causes the shells of the artificial disc to cavitate posteriorly and causes a local kyphosis, shell kyphosis across that segment. And we've learned that the hard way. And so we don't want to hyperlordose the cervical spine. We want to keep it in a neutral position. Second thing, how I define the midline. I don't use an AP X-ray. It lies to you all the time. What I do is I expose the front of the cervical spine, find the appropriate level, and then I don't put any bovie marks on the spine until I make the midline mark with my bovie. And how I do that is by looking at the longus colli muscles. I look at the longus colli muscles, I see the medial aspects of the longus colli, and just like kicking a football through the goalpost, I find the midline right between the longus colli, and I make my bovie mark from the disc space above down to the target disc, and the same from the target disc down to the disc space below. That's the first bovie mark that I make on the front of the cervical spine, and my cast bar distractor pins are going to be on that line somewhere. I don't get an AP X-ray. I stopped doing this years ago because it lies to me all the time. And the first AP X-ray I get is actually after my implant is in. And I don't look at the spinous processes. Actually, what I'm looking at is the uncovertebral joints. And I want to make sure that this artificial disc is centered on the uncovertebral joints that you see right here. You see the medial aspect, the uncovertebral joint right here and right here. And that's what I'm looking at. The problem with the spinous processes is that many times they're slanted. It's like Peyronie's disease. They're off to the side, and you don't know that, and you can get really, really confused. Also, just a little variation in technique of how they take the AP X-ray can make you confused. So I define the midline based on the medial aspects of the longus colli muscles, and most of these patients don't have a lot of anterior osteophytes. That's a contraindication in my opinion. So the front of the neck is usually very, very nice, and longus colli are a very, very good marker to help me define the midline. So the importance of the midline is to put our pins, and we want to make sure that our pins are parallel to the disc space. And what I use is the cephalad end plate of the caudal vertebra. So the caudal vertebra, I look at that end plate, and that's how I want to make my pin parallel to that end plate. And I want to make sure that that pin is far away from the target disc. When we're doing an ACDF, you can put the pins really anywhere. distractor across that segment. But doing an artificial disc, I think it's super important to put the pins parallel to the disc space, and the best approximator of that is the caudal vertebra, the cephalad aspect of the caudal vertebra. So I put that caudal pin in first, and then place my second pin, the proximal pin, the cephalad pin, parallel to that pin that I placed first. And then what's important? There's a lot of these distractors for these artificial discs have a way of making sure that there's a threaded nut that does not allow the distractor to come off the pins, because that's a common problem. I stopped using that long ago because the problem is, yeah, it stops the distractor from moving off the pins, but what it does now, it transfers all the stress to the pin and allows the pin to plow out of the vertebral body. I'd much rather replace the distractor back down on the pins, take the distraction off, place the retractor back down on the pins, then re-distract, as opposed to having my pin plow out. The other thing that I do differently is I don't use my pins to obtain the distraction. I actually use an intervertebral distractor and then just keep the distraction with the pins. When I do an ACDF, I actually use the pins to obtain the distraction. We want to be nice to these pins, especially if you're going to do a 2-level artificial disc replacement. That intermediary pin has a tendency to have a lot of stress placed on it, and you want to decrease that as much as possible. Also, it's super important to get a complete neural decompression, even on the asymptomatic side. So when I'm doing an ACDF, I focus on the symptomatic side, take the PLL on the symptomatic side, but I don't necessarily take it on the asymptomatic side. It's super important to take the PLL on both sides. And what we found out over the years is that in some people, the posterior longitudinal ligament has a tendency to, especially under motion, to develop a calcification. And the PLL, especially when you increase the motion across that segment, in some genetically predisposed patients, they can lay down a lot of bone at the PLL and actually redevelop not only radiculopathy, but even myelopathy that I've seen. So I take the PLL on both sides, completely remove the posterior longitudinal ligament when I'm doing an artificial disc replacement. Also, I use nonsteroidal anti-inflammatory medications for 2 weeks post-operatively. That's certainly different than what I do for my ACDFs. And I let them use the NSAID of their choice. If they don't have NSAID of their choice, I tell them Aleve twice a day for 2 weeks to prevent heterotopic ossification. There's some really good data to support the fact that NSAIDs do decrease and limit the incidence of heterotopic ossification after cervical arthroplasty. So I'd like to take a little time to talk about end plate preparation. Super important to understand that the end plate, the caudal end plate, is not a flat surface. Because of the uncovertebral joints, as you see here, it's more of an ellipse. It's like a football. It's shaped like a football. And all of these artificial discs, we're placing basically a flat surface on this football. Some of the artificial discs have a dome, but basically that's for the cephalad end plate. But for the caudal end plate, almost universally, it's a flat surface. And it's important to understand that we need to make this flat. And in many patients, there's actually a lot of osteophytes and asymmetric osteophytes that cause difficulty making a flat surface for our artificial disc. And I'm sure you've seen some of these sort of funny looking artificial discs, as you see right here. This is all because of this medial uncovertebral osteophyte that you see right here. Do you see this right here? This osteophyte that's right here. Now, this guy obviously found the midline. He found the midline for this artificial disc on the caudal end of this fusion. But up here, I can tell you exactly what happened because it's happened to me in the past. He ran into this medial uncovertebral osteophyte. My hunch is he was decompressing this side here. He's probably standing over here, decompressing this side, got a good decompression here, sort of ignored this side. And this artificial disc is not placed in rails or keels. Basically, he's just slammed this artificial disc in, and he probably started in the midline. He probably started absolutely perfect. But as he went posteriorly, because of this osteophyte on the medial aspect of the uncovertebral joint, the artificial disc slid laterally. Artificial discs just go, they're just they go to the side of least resistance, and that's exactly what happened here. It canted off to the side here and left this really goofy looking AP X-ray. Even the lateral X-ray is goofy that he's not going to like from here on in. But it all has to do with this medial uncovertebral osteophyte, and how I take care of that is with a barrel burr. This burr cuts only on the sides, and actually it spins opposite the way of the cutting flutes, and so it really just smooths. It's a smoother. So I place it in the midline and then just smooth medial, or I smooth laterally, go back and forth, as you see right here, and just smooth out that medial uncovertebral osteophyte to make a very, very flat surface for that end plate to allow my artificial disc to sit. So finally, in my opinion, the most favorable candidate for an arthroplasty, single level focal disc herniation causing a radiculopathy in a young patient with normal facet joints and no significant degenerative changes. I will tell you that 2-level arthroplasty, I think what we're finding out now, actually is a very good indication as well, and probably is better than a 2-level ACDF. But if you keep these indications pure, you're going to be very, very happy. When you start expanding these indications, in my opinion, that's where we see all these problems. So again, thank you so much for your time and attention, and I really appreciate the honor of being here. Thank you so much, Greg. And we'll open it up for discussion.
That was awesome.
Hopefully that was under 20 minutes. I think it probably was. So
Yeah, you rocked it.
So.
Any questions from the group that's on?
Hey, Dr. Sasso, my name's Mike. I'm one of the fellows here. Appreciate your taking the time to talk to us. That was really good. As someone who's getting ready to go out, I'm kind of trying to get my spiel in terms of counseling patients regarding ACDF versus cervical disc arthroplasty. And if you could summarize kind of your impressions or how you're counseling your patients with 20 years of data, what are the benefits of doing a cervical disc arthroplasty in the appropriately indicated patients compared to an ACDF?
That's a really great question. I'll tell you that overall, I end up talking most of my patients out of an arthroplasty. I have a lot of patients coming in. They've done a lot of reading on the internet. They are convinced they need an arthroplasty, and they have absolute contraindications to a cervical disc replacement. So that's, I'll tell you just straight off, that's the most common discussion I have with patients on why they're not a candidate for an artificial disc replacement. On the other hand, I will tell you that again, as my last slide hopefully conveyed, I think there are patients who are really good candidates for artificial discs. And those are young patients with a focal disc herniation causing a radiculopathy, a unilateral radiculopathy. They have a otherwise normal disc space, and because of that, they have normal facet joints, and they just have a big disc herniation causing a radiculopathy. And I think those patients are good candidates, are really great candidates for an arthroplasty. And what may be a benefit, maybe, and I'll tell you, I'm not exactly sure of this, but we may decrease their incidence of adjacent level surgery in the future. I'll tell you that I don't think that there is any short-term benefit, even though you will see that in our papers show that there is statistically significantly better outcomes, especially in NDI, of arthroplasty over ACDF. It's not clinically important. There's only like a 5 to 8 point difference, which is not clinically significant. So I'll tell you, I don't think there's clinical significant differences, at least out to 10 years, but there may be a benefit in regards to further surgery at adjacent segments. Maybe.
Great, thank you.
Dr. Sasso, can you comment on hybrid constructs and what you think of them, or when you use them, or if you don't?
Short answer is I don't. And the reason is that I don't really know what the indications are. there's a lot of papers written about hybrid constructs, but I will tell you, there's no good prospective randomized trial on hybrid constructs compared to either fusions or a two-level arthroplasty. I understand some people's thoughts about why a hybrid may be done, and it may make some sense, but the problem is there's really not good data to support, at least my opinion, hybrid constructs. What are your thoughts about hybrids? What do you think about a hybrid construct and why you would use it?
I'm not sure I would ever use it because I think there's degeneration that's happening, and if that's why you're doing the ACDF, then they may already be on that cascade. I suppose if there's a pristine disc with a disc herniation above a terribly degenerate, I don't know. I don't think there's a great. I'm with you, Rick. I'm really on the conservative end for TDR. So I'd rather have and the only reason is because I've had my share of failures. And it's always because I chose the wrong patient, not because, that's the main reason, is like, I should not have done that on this patient, So that's always my biggest regret, is like pushing the limits on facet arthropathy or a vertebral joint hypertrophy or too much degeneration, and so like I've definitely found my indications getting tighter. But I think I've learned that from you and the guys that talk about it honestly. You're just like, listen, like, you revise too many of them, right? It's just, then it becomes a problem.
The problem I have with hybrids is the first time I ever heard about a hybrid, it was a gimmick because guys couldn't get arthroplasties approved. So they had a patient approved for an ACDF, and then they did an arthroplasty adjacent to that. And so that always made me scratch my head a little bit about but I do think it's coming to be kind of a real thing. I mean, as Greg said, there may be an indication when there's a disc herniation in a relatively normal disc space next to a disc that's pretty arthritic, and you're concerned that may progress. But then if you're going to do an arthroplasty at the large disc herniation level, then why do the adjacent level when our thoughts are that maybe we can prevent further degeneration at that level? So it just is not intuitive to me.
So one more question, Dr. Sasso. When you showed your cast bar slide, it looked like there was a guide that was in the disc space to set that first pin. Do you use a drill guide, or are you just outputting it from that?
No, what that just showed, that's a good point. In some prototype stuff, we had some of the original arthroplasty techniques. It's to get people to get the pin far away from the target disc. And in some artificial discs, because of how you do the end plate preparation, you need a certain amount of space, and you got to get your pins out of the way. And so that was to show surgeons how much room, the minimum they had to have the pin away from the target disc. Nowadays, I mean, I just look, you don't want to put the pins in the disc spaces above and below, but you want to get them as close as possible to those disc spaces without being in them. You want to get your pins very, very far away. We're doing an ACDF. It doesn't really matter. I mean, it hinders us a little bit if our pins are close to our target disc. But doing an arthroplasty, depending upon which arthroplasty you're using, sometimes you absolutely handcuff yourself because you can't get your disc prep. Whether it's a cutter for rails or a keel cutter or whatever you're using for the prep may be blocked by your pins if they're too close to the target disc level.
So I have a question for you, especially as it relates to our fellows going out, and let's say they sign up, some TDRs, and they're in the operating room. And at what point, like, what are some things where you're like, oh, this is just not happening, I need to convert to ACDF? Like, what are those things, like, intraoperatively, where you're like, okay, I'm not doing this patient a service by doing the TDR?
Yeah, and I'll tell you, that goes back to actually discussing this with them. I tell all my patients that if I don't feel that it's safe for them to put an artificial disc in, they're going to get an ACDF. And I tell them, you know, that that's not a bad thing. ACDF's a great operation. And I actually have the consent form signed for an ACDF if I can't safely put in an artificial disc. And I'll tell you, this goes back to the early days when it was a patient, just as I showed you, that I did not think I could safely put an artificial disc in. And so I called an audible, did an ACDF, and boy, they were upset. And they were upset, and appropriately so, because I didn't tell them beforehand that there was a possibility that they may get an ACDF. So tell them beforehand they may get an ACDF. And then intraoperatively, if you are ever concerned that it is not safe to put the artificial disc in, don't do it. Again, the most common for me is that I can't see the back of the disc space. That's usually at 6'7" and a big man. The second most common is, and this was when I was doing the trial for the Bryan disc a long time ago, the smallest diameter disc we had was 14 millimeters. And in some Asian women, that's too big. And you can't place a 14 millimeter in a small Asian woman. So that was the second most common reason. And the third is there are some patients where when you distract that segment, especially in a very degenerated segment, and this is where my indications got a little too wide, there's no compression, there's no soft tissue compression back on that disc. And so you distract out. I think it has something to do with facet joints, sort of you break open so they're used to being shingled on each other. You distract that out and you put that disc in and it's just wobbling and there's nothing compressing back on it. I think that's a bad segment to put an artificial disc in. And that's the third most common reason that I've changed, called an audible and did an ACDF.
Okay. Yeah, it's super helpful. So do you, on all your, like, is the consent that you put out for, is it, you know, C5, 6, total disc replacement or whatever, cervical disc replacement versus anterior cervical discectomy fusion?
Possible.
Or?
Not very, it says possible. If
Okay.
I can't safely put it in, you know, the goal is to do it. And the vast majority of the time we can do it, but they all know that if I can't safely put it in, they're going to get an ACDF and they should be happy about it because that's a good operation as well.
Okay, good. I think those are critical. Those are the critical points, you know.
Right, because if you don't do that, then when you are in the operating room, you feel really compelled. I got to do this. I got to put an artificial disc in because I told them I was going to do an artificial disc, and there's really no bailout for me. Give yourself a bailout.
Amen. Awesome. Well, thanks, Rick. I think we're right on our 7 o'clock time mark, and it was an awesome honor to have you, and hopefully we'll keep you engaged next year as well. And thanks for imparting your knowledge, and I'll see you next week.
Fun. Can't wait.
Man.
Thanks, Rick.
Guys. Good luck to all you fellows.
Thank you.
Thank you.
Thanks.